I'm Girish Rao, one of the pediatric hepatologists at Riley. I'm also the medical director for the pediatric transplant at Riley. And I've been here at Riley for, I think, 17, 18 years. And Jean has been here for, 20, 25 years. So we've been taking care of kids for many, many years. The way we have broken down this session into 3 talks, but it's going to be very interactive. So it'll be very informal. Interrupt me, ask questions. So there will be slides, but that's to guide our conversation. So I'll be talking a little bit on the treatment and outcomes. Then Jean is going to talk about the transition issues. Then Elaine is going to talk about dealing with the chronic illness, the psychological issues, and how to cope with that. So I'm going to get started. This is a medical definition. So in the most simplest form, you have a child who's got increased liver numbers. You have positive autoantibodies, which you are aware, like the ANA, the smooth muscle. Then we do a biopsy. It shows inflammation. And the inflammation for a classic autoimmune is the presence of cells called plasma cells, or a combination of plasma cells and lymphocytes. So it's a combination of clinical lab testing plus the liver biopsy all put together. That's the autoimmune hepatitis. And that's in the simplest way. There are layers to its complexity. I'm not going to go into the minor details. We can have discussion. Example, your son has the combination of PSC, autoimmune plus Crohn. So that's a subcategory. Yeah, it's not common, but that's a very unique, in addition to just a simple, straightforward autoimmune. So this is, already heard type 1, type 2, so which you are very familiar. So the type 1, typically, it's the teenage patients, in contrast to a type 2, which is typically an infant, so 6 months, 1 year, 2 years. And the other thing about type 2 is much more common to be acutely sick. So usually okay, then all of a sudden sick, then it's almost like going into an acute liver failure. So less common with type 1. So the patients I've seen is always a type 2 who comes in with a liver failure. The other striking thing about type 1 is we pick up many patients who are quite advanced in their liver disease. We have many who are cirrhotics, which is completely like, family doesn't know, and by the time they come to us, the liver biopsy shows advanced cirrhosis. So that's again common with type 1. Then looking at the autoantibodies, the type 1 classically we say it's an ANA and a SMA autoantibodies. For the type 2, it's the LKM antibodies. Then I touched upon the histology, cirrhosis versus more necrosis. That means there is more cell death in type 2 versus in type 1. And I'm going to talk a little bit more about the last column about immunosuppression. We'll talk more. So which can be weaned out, which we cannot wean out. So we'll talk more in the next slide. Okay, so how do we diagnose an autoimmune? So when I have a child who comes to me with an elevated liver function test, we run testing to make sure there is nothing else going on, including infections, other conditions which can cause chronic liver disease like alpha-1 antitrypsin deficiency and other things. Once we exclude, then we do testing more specific for autoimmune liver disease. So this is just to show you like a liver lobule how it looks. So you have a liver cells, blood flow between the liver cells, then the arterial supply there, then the venous drainage back into the central vein, into the hepatic vein, then the bile ducts. So everything kind of centers around when we do testing. It's the AST, the ALT, the GGT, alkaline phosphatase. You're talking about the pathology happening in this liver unit where things are happening and causing them to go up. So what test are we looking? We'll start with a liver function test. So typically you have elevated AST, elevated ALT, and the GGT can go up. And we can talk more about the overlap syndrome, which is seen much more in pediatrics. So what's the overlap? So typically in autoimmune, it's the liver cells which are inflamed. Typically the bile ducts are not so involved. But in pediatric autoimmune, unlike adult, there is a lot more involvement of the biliary tree. So that's the autoimmune sclerosing cholangitis. That means there is inflammation. But again, unlike adult, the pediatric patients do respond well to the immunosuppression. So even though there is inflammation of the both liver cell and the bile duct, but they respond well. So that's the overlap. So if you have a patient, I have a patient who has high GGD, that makes me think, this patient probably has biliary involvement, even though my approach may be similar how I treat it, but I may do a additional testing like an MRI test to look at the biliary tree to make sure there is no narrowing of the biliary tree, or if there is something, we can help and intervene. In some, yes. Yes.
Well, so I also have PSC.
Mm-hmm.
I did pre-transplant.
Mm-hmm.
And so what I've noticed
Mm-hmm.
from my personal experience, so it's purely anecdotal, not research backed, but I have seen like more pediatrics who start off with PSC then develop AIH
Mm-hmm.
than pediatrics with AIH who develop PSC. But I had AIH first, then PSC.
Mm-hmm.
So do you know why that is, or if that is research backed in any way?
I think, the way I will look into it is probably you had AIH to start with, probably you had overlap.
Mm-hmm.
So you had involvement of both the biliary tree and the autoimmune liver disease, and later on you had more progression of the liver disease, and that led into cirrhosis. So it's not like one turned into other. Probably you had both to start with, because 50% of pediatric patients, if you test everyone and look for involvement of biliary, 50% have involvement. So almost 1 out of 2 have biliary involvement. So over time, that can progress. So it's not like PSC happened later. Probably it was there together. Then it evolved over time, got worse because you developed cirrhosis. So that's how I will look at it. In the past, we were not that knowledgeable about the ASC, but now it's a common knowledge. A lot of the pediatric centers, we know that autoimmune patients have associated biliary involvement. How much it varies. There are some patients they're okay, and others is much more progressive, much more evident. So our approach may be a little different. So I think in your case, probably it was a combo to start with, and then it got worse over time.
So it wasn't like really showing up in tests before because it's so hard to diagnose?
It is somewhat, you're right. Unless you do a biopsy, you follow up, you do an MRI test like the MRCP, you're really after it, it may be hard to pick up. Because again, the patients I had to go back and look at it, then the GGD goes up. I'm like, okay, maybe, I missed it. I go back and look at it, yes, they had involvement. Or you go back and look at the biopsy, probably there was involvement. Anything to change? Yeah.
I just noticed something, because this morning they talked about how prevalent this is in females, but
Mm-hmm.
son.
Yeah,
son.
I know, yeah.
So.
Well, that's,
The split in kids
Yeah.
is not as female predominant.
Yeah,
as
it
adults.
is.
I'd have to look that
Yeah,
up.
it is
to
true,
be
it's
sure
true.
I'm
Yeah,
right,
it
but
is
I
true.
think I am.
Yeah. It is, yeah. I think the adult it is much more male female to ratio, but in pediatrics less so. But again, if you look at my patient population, you're right. I think I have a mix of both boys and girls. I think it's more of a even split than the what we see with
They
adults.
talked about the gene or the 301 or 401, I can't remember the exact numbers for it.
Mm-hmm.
But is there a difference between adults and children, one gets one versus the other?
No, don't. Definitely, like in all autoimmune diseases, there is a genetic predisposition. Period. There is a predisposition, so they are at risk, and something else triggers that autoimmune process to become evident and causes the liver damage. So you have a predisposition, then something else happens and leads to liver disease. So what does the set of gene combination, which gene combination, which is the trigger? It's hard to pinpoint. Okay, so going to the next one, majority of patients have the increased levels of the immunoglobulin, which is made by your body's immune cells. So that's the reason why a child gets the autoimmune liver disease. So their levels are higher, and there are some patients where it may not be very high. So that's again helps you to corroborate your diagnosis. So something to check. Then we talked about the autoantibodies, but again, there is a biopsy-proven autoimmune patients where you may not find any autoantibodies. So that's a seronegative. That means the ANA is negative, smooth muscle negative, LCAM negative, But you do a biopsy shows classic features. There is inflammation, there is cell death, there is lymphocytes, plasma cells. Then you don't have to have the autoantibodies to say this is autoimmune. So that's a seronegative. Or there are expanded panel that you can run to look into it. But to me, the way I look at the autoantibodies, it is helps you to come to a diagnosis, but never lets you say this is it, this is the diagnosis. Then I did not mention here about the scoring system, which there is a scoring system, autoimmune hepatitis scoring system, and that gives you points for each of those. Your age of presentation, histology, autoantibodies. When pediatric patients, most of the time it's clinical. We look at the biopsy, make a diagnosis. We less rely on the scoring system. So what to look in the blood count? It depends. If the patient has more advanced liver disease, you may find low platelets, you may find low white cell counts. Then the coagulation test, it tells you how the liver is working, may show increase in the clotting number. That means the liver has suffered more injury, and the numbers go up. And sometimes it could be just because patient has not had enough vitamin K, because they're not absorbing the vitamin K well. Then the numbers go up. So if it is correct with vitamin K, that's a good thing. If it doesn't correct with vitamin K, that tells me that the patient has more significant liver injury compared to somebody who has correctable PT and INR. So it's a combination of tests to get going. Then you can typically do a scan. That tells you a normal liver, and those are the blood vessels going into the liver, the artery in the red, the blue is in the vein. So in an autoimmune patient, the liver may look more brighter. Go ahead.
So my daughter's pro-time numbers are usually pretty increased. So she has von Willebrand's disease, so she doesn't clot well. So when we do her tests, it usually is always elevated. Is there any way to decipher if that's from her liver or her, because like her age, her ALT and her AST, right? Yes. Sometimes are good, sometimes are bad, whatever, up and down. But our pro time is usually always extended.
How much is the pro time? How high is the pro time?
We vary, so it depends on if her von Willebrand is active at the time or it's not.
Yeah. So the only way, and I think if you really want to pin down, you can look at the factors which is made by the liver itself. That will really pin down, if the factor 2, factor 5, factor 7, those are okay, that tells you the liver is doing a good job. So, but those assays are, expensive, and generally, I hardly ever do it, only setting I sometimes done it. I have a patient in the ICU who is sick, who is in liver failure. I really want to know, then I check those levels. But in a day-to-day, I hardly ever do it. But again, if the question is for you, like how do I know what's what, then you can do an assay of the factors. And if the factor levels are, say, 90% of expected, that means the liver is doing a good job. So that may help you to tease out a little bit better, how much is van Willebrand versus how much is actually the liver. Okay. So that may be at least if you do once and know the numbers, then at least it tells you it's not coming from the liver.
Yeah. Okay, cool. Thank you.
Yeah, so on the imaging, typically I do ultrasound to start with. It will show me how the liver anatomy is liver enlarged. It tells me how the liver looks. Typically, when the liver inflamed, it looks more brighter. So you see more, brighter, like how this area looks, and or you may see liver being enlarged, or it may be shrunken. It may look it has cirrhosis. You may see a bigger spleen. That is a sign of portal hypertension because the blood is backing up into the spleen, so spleen is getting bigger. Or you may see fluid in the belly. The site is much more advanced liver disease, so the belly it's filled with fluid. So less common, but more so in bigger liver, bigger spleen, and liver looking brighter. So this is pretty much everybody gets the ultrasound. The next step, if you want to go into the overlap syndrome, autoimmune sclerosing cholangitis, PSC, then we do a special test called MRCP. It's an MRI test, but the MRI test to look at the biliary tree. And so they inject a special contrast, it looks at the biliary tree, and that tells me whether the ducts are narrower, if there is any narrowing inside the liver, outside the liver, if there is involvement. So that's the autoimmune plus the sclerosing cholangitis, that's the overlap, or pure PSC without an autoimmune. So that helps you to differentiate. So routinely I don't do it, but if I have a patient who has high GGT, suboptimal response to what I'm doing, so sometimes I go ahead and do an MRCP to get me more data. Okay, then comes the histology. So this is where, at least for pediatric patients, we rely a lot to make the diagnosis. So on the rightmost side is the normal liver. So you see a portal vein, which is then you the liver hepatocytes, the liver cells. Then there is a bile duct and an artery. So that's the normal. In the middle is a biopsy from a patient with autoimmune liver disease. So you can see it looks very busy. It looks, there are a lot of blues. Those are all the immune cells, lymphocytes. And we talked about the plasma cells, which are these large cells. So presence of these cells along with the smaller blue cells in the portal tract, and the inflammation is going into the between the liver cells. That's classic for autoimmune hepatitis. The medical term we use is called interphase hepatitis. So liver lobule is more like a, it's like a one unit. It should all be confined in it. If the inflammation goes beyond, that's called interphase hepatitis. So that's classic for autoimmune. Then you look at the cell. The terminology is plasma cell and a lymphocyte. So if you have all that put together, then that's an autoimmune hepatitis. Sometimes it's not very clear. You may not see the plasma cell in every patient. On average, I will say maybe 50–60% of patients, and you may see a plasma cell. But lymphocytes, yes. Then you look at the pattern of inflammation and make a diagnosis. How do we do biopsy? Typically, you go through the skin, and if a patient has prolonged INR or has a bleeding tendency, then we typically go through the neck vein, get the liver tissue to establish a diagnosis. Questions? Okay, so I'm going to switch gear to talk about the treatment. So before you even talk about the treatment, so who should get treatment? For most pediatric patients, that's very self-evident because you have a child who is symptomatic, who has lab abnormalities, who's got high numbers, or you have already done a biopsy for some other reason, and the biopsy shows there is florid inflammation, so it needs treatment. In the adult, if you look at the guideline from the Liver Society, they put a category saying treatment not needed. Those are patients who have normal LFT and almost a normal liver biopsy with some inflammation. So if the inflammation is minor and you have a normal liver numbers, then you are not required to treat, because that's your goal of autoimmune treatment, is to make the numbers normal, make the liver normal. So if your numbers are already normal, your liver doesn't show much inflammation, then you are not required to treat it. So most of the time, that's not the case in pediatric patients. Pediatric, they are symptomatic, their numbers are high, so we end up treating them. So why should we treat, and what's our goal? First is to get the numbers normal. Once you get the numbers normal, you want to keep them there as long as possible. Why? Because you want to prevent the disease moving from earlier stage to a cirrhosis, or cirrhosis to a complication. So just to prevent the progression and prevent the liver failure. So this is the conventional treatment, which you are all aware. Your doctors have talked to you about. The medicine you use, that is the prednisone and azathioprine. So typically, what I do when I have a patient with autoimmune liver disease, once the diagnosis is established, I start them on prednisone. How much prednisone? 1 to 2 milligram per kilo. So depends, 40 to 60 milligram per day, once a day, or 2 divided doses. Typical duration, I do it for a good 4 weeks plus, then I start the taper. How much I taper? Maybe 5 milligram a week, 10 milligram a week, do a slow taper. That puts us another 8 weeks to another 10 weeks. When I'm doing that, right around week 1 to week 2, I introduce the azathioprine because for azathioprine, azathioprine is metabolized through the liver. There is an enzyme which breaks it down. So I check the enzyme to make sure that a child can break it down. And that takes about a week. So I already have done 1 week of treatment. So I get the child back in the clinic. I discuss, and I will talk more about azathioprine and pros and cons. Then I introduce the azathioprine. The other reason where we delay azathioprine, if a child is in liver failure or a child has got jaundice, he's like bilirubin is like 10, I usually delay it because azathioprine is metabolized through the liver. So if the liver is already sick, has got damage, you don't want to put azathioprine, which can itself cause liver damage or hepatotoxicity, to make things worse. So I usually cool it down, start the prednisone, cool it down for a week to 2, then introduce ASAP. Then I'm more aggressive in weaning down the prednisone. So my hope is I try in every patient in about 3 months, maybe plus, to get them down to the lowest possible dose or even try to get them off of prednisone. And by the time, my hope is get azathioprine a good dose, probably good level, so that puts me right around the 3-month window. Am I successful in every patient? No. Many patients it drags out. So I go beyond 3 months, probably 6 months. So I leave them on 5 milligram prednisone, 10 milligram prednisone, low dose, and try again to get them down. So how successful? Of all the patients I follow, I'll say 90% of my patients, I get them off of prednisone. I leave them on azathioprine monotherapy. 10% I can't, and I leave them on a dual therapy, maybe a low dose between 5 to 10. Let me switch. Okay, so that's the number from the clinical trials. So more than 80% should respond in 4 to 8 weeks. So if you do the conventional treatment, start prednisone, 80% by 4 weeks to 8 weeks, your ALT should be way better. When I say better, less than 100. Bilirubin should be normal. Clinically, the child should be feeling much better. Then, as I said, my ultimate goal is to get them on low dose or to completely get them off prednisone.
You define low, is there a certain ratio of your body weight?
So it's 0.1 to 0.2 milligram per kilo per day. So if a child is 25 kilos, maybe 5 milligram. If a child is 50 kilos, maybe 10. If a child is like a infant, 2.5, 5 probably tops off. So I would say 10 to 15 is where the low dose, we had to draw the line. 20 milligram is not a low dose. So 10 and below is low dose. 5 for sure is a low dose. So yes.
What is the data on who was 20% that don't respond on?
No, no, I don't. No, I don't think I have come across like who are the failures, who don't respond. What are the characteristics that they don't respond? I don't. I'm thinking if they have much more, again I can tell you from my personal experience, if I have a patient who had severe liver disease from the get-go, like bilirubin 10, 15, the biopsy shows lots of inflammation, AST, ALT in the thousands, I'm very, very hesitant. I'm very, very slow with weaning down the prednisone. Those are the patients where I struggle a lot, and those are the patients probably where I'm looking at my backup options and third agent or the fourth agent I'm trying. So if I have a patient who comes in AST only 200, 300, almost like guarantee that they're going to respond. So I think it's just the severity of inflammation, how bad it is. I think that's probably puts them on. But again, this is completely anecdotal, but what I've done. Gene, anything you have seen?
Probably the most severe ones
Yes.
are the hardest to get off. And also, you're more afraid to take them off.
Yeah.
My daughter got off though, and her bilirubin was 14, and her liver enzymes were 1800.
Mm-hmm.
And she was able to get off.
Get off.
Yeah, it
Yeah.
took us a long time.
Yeah.
Don't get me wrong. We were
Yeah.
on for 9 months.
Yeah.
Almost 10 months.
I thought I heard, I heard somewhere, that when kids, I don't know if this is adults too, but come in with like really high
Mhm.
ALT and ASTs, that sometimes that actually they do better than the ones that are like simmer at sort of like in the 100s. Did I make that up?
At least my personal experience, no. I think I struggled I know like which patient going to give me trouble, like which patient is I'm going to struggle to control. Are the ones who are like in the ICU type, who are almost to the liver failure, just got out. Not the ones who I diagnosed because the pediatrician did a lab test, the ALT was high, I do the screen is positive, I do biopsy is on multi-moderate autoimmune. I'm able to, mostly, 2 agents we are able to get it under control. Okay, prednisone, everybody knows the side effects. So it's a slew of side effects, and especially for a child matters because if you're dealing with a teenager, which is the type 1, which we are most of the type 1, there's the weight gain, the body fat distribution, they get truncal fat and the hump, the skin gets stretched, acne, then risk of infection. Then for a toddler or the child who is growing is a growth retardation, so their growth stunts. And that's one of the reasons where I'm very aggressive in getting the prednisone down to the minimal or to get them off because it's effect on the growth. Then bone health, cataracts. If you are on a high dose for a long time, risk of diabetes, hypertension. Then teenagers, we deal with depression. So on top of their chronic condition, you put prednisone, it makes it very hard for them. Azathioprine, and I told you how we introduce it. And I do the test called TPMT test. It's most of us do it nowadays. It's easily available test. What it tells me how much to use. So if TPMT you have both the TPMT enzyme genes, you are able to break down. You have one missing, you use half the dose. You're missing both, don't use it or think an alternative. So that tells me upfront. So instead of trying it, because if you ask me what's the rate, 80% are normal, 10% missing, 2.5% have nothing. So
And that tells you how you metabolize it, right?
how you metabolize it,
Yeah.
yes. How you break it down. So I check it, then I start, and it helps you to get the prednisone dose to a lower dose. Then I, typically, I don't routinely do in every patient, but you can actually check the blood level to see how they are doing it. I do it in patients where I am not getting good response and where I have to really push hard. And there is no data in children with autoimmune, like what the good dose and what the good level. The data comes from patients with Crohn's and colitis. There, anything about 200, 300 is a good level. So if I have a patient I struggle a lot, I push it to 200 to 300s. Then also you can look at the blood count, make sure the blood count is not dropping. That helps me to monitor the disease. And we talked about not to use it with acute liver failure.
Excuse me. So as the child is growing,
Mm-hmm.
Do you continue to do the TPMT test?
No,
or-
this is why it's a gene. So one time you do it,
Okay.
you know what the phenotype, what the child has. You don't have to repeat it.
Okay, so then
Yeah.
how do you judge the increase in the urine?
The dose, you can do the blood test of the level itself
Okay.
and see how much.
6
6 Tg level.
Okay.
Yeah, so the azathioprine goes into liver, gets broken down into two 6 Tg and a 6 mmP. And you can measure how much it is, and you can decide where you want to target.
Gotcha.
And more than 200, decent goal. Above 300, 350, start looking at a complication, which is your bone marrow starts getting suppressed. So the good dose is 200 to 300. Yeah. Side effects, we talked about marrow suppression, nausea, vomiting, abdominal pain, rarely pancreatitis, which is your pancreas gets inflamed. Liver toxicity we talked about. Malignancy, I do talk about with my patients, but in reality, the risk of cancer because of azathioprine in the setting of autoimmune liver disease, I'm not aware of anybody developing a cancer. So, but if you look at the printout about AZA, it's there. There is literature in the IBD world about azathioprine and cancer risk, but the same data I don't think we can apply into pediatric, but I do mention it. Then it's a balance of risk and benefit. Then you have a liver disease which you have to control. Then I think it's worth the risk and we use it. Again, this medicine has been used for now decades. So at least in the medical literature, there is not a whole lot written about cancer risk, specifically azathioprine in liver disease. So to me, I reassure my patients that it's safe to take it.
Question, just out of curiosity, do you all put kids that are on azathioprine and Remicade, will you do that combo dad?
So that's a very good point. So if you ask my colleagues,
Because
yeah.
there's some research that there's matters.
So I think now, I think at least, the current consensus is the risk of IBD-related malignancy risk, the type of lymphoma we talk about, I think is related to the azathioprine. And I think the combo may be some risk, but I think it's more related to the use of azathioprine itself. So if you ask my group, I think a lot of them are trying to go with a monotherapy. And if they have a teenage male patient, they are looking at alternatives because that's the high risk for complications. They're using methotrexate or some other alternative. But there are others, who use it, and there are the backup.
Yeah.
But we have to.
Yes, we have to, yeah. How do we monitor blood counts, liver function tests? We talked about 6TG. Bone health is something I bring up because if you have a child who's been on prednisone, who has struggled, I think it's a good idea to at least do sometime a bone density scan to see child's bones are not getting, osteoporotic. There is no guideline, in the pediatric literature about how soon you need to do it, but I have done it in my patients. If they're on prednisone off and on, they're growing, I do it. And I try to tell the families, make sure you get vitamin D, make sure I check the vitamin D level, make sure your calcium intake is good. I do push it, but once in a while, if I'm worried about it, I do the bone health.
So if my daughter's on a vitamin D supplement already, do you think that would cause it?
No, it is the steroid-related effect. So if you're on steroids, it makes your bone brittle.
Right.
So if you supplement vitamin D calcium, you're good.
Okay.
Yeah. So the bottom line is make sure your child is getting enough vitamin D, enough calcium. Have a discussion with your doctor. Make sure it's optimal, and you can check the vitamin D level. Despite that, if you worry about it, then you can get like a bone scan. Just a word on ultrasound and what is called AFP, alpha-fetoprotein. Liver cancer in autoimmune is very rare. Even in the adult patients, it's about 5%. So pediatric, I have not seen one. It's very rare. If you have a patient with cirrhosis, child is cirrhotic, then there may be some validity in doing an ultrasound once in some time to look at the liver. But again, there's no guideline. But again, if I have a child with cirrhosis, I have done the ultrasound in the AFPs, but again, there's no guideline in the pediatric world. How do they respond? 90% we can induce remission, 10% we can't. So when I say remission is prednisone azathioprine, so 10% they fail, and duration of therapy is usually several years. So how many years? At least 1 to 3 years. 3 years is probably the least. Probably it's several more years. And I'm gonna, okay, so when do we stop? This question I get asked by every parent. When can we stop the medicine? Those are your bullet points. Child has to be completely asymptomatic, has to have a completely normal liver function test, has to have a normal autoantibody. That means if a child had a positive ANA, positive smooth muscle, when we are treating, that should become negative. Your immunoglobulin levels should become normal, and you have to have a normal liver biopsy. So if you meet all those 5, I think then to add to that, if it is type 2, it's probably not going to work. Type 1, probably you have a chance to make it work. And even with all that, success rate is under 20%. So 80% patients, once you withdraw, if you try, is going to relapse. So most patients need some kind of immunosuppression of some level. So you can try, if you meet those criteria, monitor closely, but be prepared to intervene if the numbers start going up. So bottom line, most children will need some immunosuppression long term. But it's, I'll go to the next slide. Okay, I'm not going to go into the depth. There are several medicines that we can use if your therapy fails. Cyclosporin and tacrolimus, those are the 2 medicines we use for transplant patients to keep the liver in. So if you take the same concept applied to autoimmune where your body is rejecting your own liver, it works, yes, and I gave you the numbers. So those are the remission rate in patients who have failed conventional. So 85%, 90%. Side effects, a lot. I'm not going to again go into depth about each of those side effects. Most commonly, we use mycophenolate, or called as Cellcept, as your second agent. Example, you have an azathioprine, intolerance, complications, you don't want to use it, that's your backup. How good? About 70%. Side effects, most common GI, nausea, vomiting, diarrhea, abdominal pain. But again, we use it much more than tacro or cyclosporin as a salvage treatment, as a backup. Budesonide has come into picture recently in the last, say, 5 years. There is adult data to show it works. What is budesonide? It's a steroid. The difference is, unlike prednisone, once a child takes the pill, 90% gets broken down in the liver, 10% gets into the body. So the side effect, weight gain, acne, stray, all that, very minimal. So in some teenage patients who are not want to take steroids, that may be an option. And I have some patients where I have a liver biopsy which already shows fatty liver and also has like an autoimmune feature. I have done a budesonide treatment. There is adult data to show that it kind of works, but again, the number looks 50-50, so it's not like great numbers. The others I'm not going to skip over. Example, infliximab, which is used in Crohn's patients, PSC, autoimmune, case reports that it does work. There's a medicine called rituximab, which affects your cells which make the immunoglobulins. Again, case report. So there are options one can try if the traditional treatment fails. Okay, transplant, uncommon, less than 10%, I will say more like 5% of pediatric patients. Survival rate, excellent, 90%. But like all autoimmune, you have a chance of recurrence, 30%, roughly, rough number. PSC, 30%, autoimmune liver disease, 30%. That means even if you put a new liver, that new liver can have the disease in about a third of the patients. Then you have to treat it. Why? And those are the reasons. Your liver disease is progressive, you have acute liver failure, or rarely, cancer. Those are your numbers for outcomes. Remission, type 1, 97, 87. 6 months median time. Relapse rate, this is on treatment. You are cutting down the medicine, cutting down your normal numbers flare up. That can happen nearly in half the patients, but it's manageable. Transplant in the bottom, 6% was 13%. This is from one center. This is from UK, King's College. We had a large pediatric patients. So it's the data from UK.
So what's you come off the medication and your blood work just starts going bad again?
Yeah, that's the relapse. So yeah, if the stopping medicine, I told you, so that's 80% relapse. Here the relapse is you decrease the medicine, you're already down, you're normal, the numbers go up. That means you are on a stable course, numbers go up, then you intervene, maybe up your steroids, maybe put back steroids, control and bring it back. So that happens as in almost 1 out of 2 children relapse, but it's treatable.
I have a question going back to the transplant. So with the 30%, okay, so I went to Cincinnati Children's for like 10 years, and then last year I switched to adult hepatology because they were like, you can't do your transplant at a children's hospital. Like, they were fine with it, but like the anesthesiologists and social workers and stuff, there's a lot of teams on the transplant. So they sent me to adult from pediatric last year. But with the 30%, I was just talking with like my new hepatologist, and he was saying that like post-transplant, if it comes back, then it's harder to control.
It is somewhat, but typically what we do, if we transplant a patient who has an autoimmune underlying, we are very aggressive from the get-go with immunosuppression. So you are more immunosuppressed. You are on 2 agents from the get-go instead of 1. So typically, my patient gets, say, biliary atresia, which is where the most common reason for transplant in children. We usually use 1 agent, tacrolimus. But in autoimmune, Cellcept and the mycophenolate and tacrolimus, we are more aggressive. So, but I think it's treatable, but I think, I know the PSC data, it's much harder. They recur, they are more aggressive. I think it's treatable, but it's much more immunosuppression than your normal.
Because so whenever I was diagnosed, I was like in the thousands, and then until transplant, like they were never normal. Like, but eventually I did go off for like a little bit. I mean, I was still on like Ursodiol and stuff, but I wasn't like Imuran and prednisone for like a few years. But like they were saying that was going to be like the lowest it was going to be possible. So even though it wasn't like a normal range, then it was still okay to take me off for like a little bit.
Yeah, I think sometimes we do in some patients where you will never reach the normal ALT. So you say I'm okay with 100 because it's a balance between how much you can immunosuppress you. So you'll say, okay, ALT of 100 is okay. I'm going to do a combination of Cellcept and tacrolimus of this level, because if you take them too much of those, they have complications. So it's a balance. So yeah, you may not be in 30, but 100, 120. Otherwise, your functions are good. probably that's okay too.
Okay.
So I have done it, in my patients. So, it's okay. So, kind of summary slide. Good prognosis. Most do well, even with cirrhosis, which is seen in about 40% of pediatric patients. They do well. So cirrhosis. So if your doctor tells you cirrhosis is not the end of the world, so that's not the end. So they can be treated. Long-term immunosuppression, withdrawal only in 20%. Cancer rare. Transplant need less than 10%. I think I'm way over. So I'm gonna step. Let Jean take it.